Hi, I'm Alex. Today I'm talking about briefly my view on obesity um, and why major medical organizations consider it a disease per se. I am a personal trainer and I have been for some time, so the argument can go both ways. It's either a disease or some cases it's not a disease. Um, and then I'll recommend one medication based on a surgical option for clients trying to lose weight. Um, so, what is obesity? The view in today's society is very incorrect. It's more than just food. Obesity is more than excess weight. Clinically, it's often defined by a BMI greater than or equal to the range of about 25 to 30. Um, with obesity related conditions. But BMI is like the only crude measure. That's kind of where you start at the basis of it. Obesity is very complex. It's a chronic condition with biological, environmental, behavioral, and social drivers. That means it's not simply a failure of willpower or the lack of motivation to get up and exercise. Um, Genetics, gut-brain signaling, hormones, food environment, socioeconomic factors, and more all interact to cause and maintain excess adiposity. Um, Treating obesity effectively, therefore, requires medical, behavioral, and sometimes surgical or pharmacologic interventions. And why obesity is considered a disease myself. In 2013, the American Medical Association and several international organizations recognized obesity as a disease because obesity meets key criteria used to define disease. It has recognizable signs like the excess adiposity, measurable pathology, like dysregulated energy homeostasis, adipose tissue inflammation, metabolic changes, predictable natural history, progression to comorbidities like diabetes type 2, cardiovascular disease, sleep apnea, and it benefits from medical interventions. Recognizing obesity as a disease shifts the conversation away from moralizing behavior and toward clinical evaluation. Evidence-based treatments and insurance coverage for therapies. Some short evidence that I found, large trials and reviews shows that newer drugs like the, I think it's the GLP-1 receptor agonist and bariatric surgery. It produced clinically meaningful weight loss and improved metabolic outcomes. For example, once weekly, semaglutide produced sustained 15% weight reductions in clinical trials. Newer multi-agonists are showing even larger effects in the early studies. Bariatric surgery shows the largest and most durable weight loss and remission of diabetes for many patients. So some recommended options that I actually was learned during my training school in Chicago. It must be individualized by your goals, medical history, BMI, comorbidities, prior weight loss attempts, risk tolerance, and excess insurance matter. One that I strongly recommend is the GLP-1 receptor agonist, the semaglutide that I mentioned. I recommend it because strong trial evidence for clinically meaningful weight loss, improved glycemic control, and cardiometabolic markers for many people. Effective for clients with the 27 to 30 BMI or higher, with comorbidity who prefer non-surgical care. You can expect 10 to 15% average weight loss over a year in many trials, but individual response varies. Like if you're consistent, if you're eating correctly, exercising correctly, the medication is not going to work on its own. You have to do your side of this in order to see the results. Side effects commonly include GI symptoms, nausea, constipation, diarrhea, and rare risk of gallstones. Medications typically require ongoing use to maintain effect. Stopping often leads to regain unless concurrent lifestyle changes and maintenance plans are in place. And regular follow-ups and monitoring are required, just to see if you're moving too quickly or too slow, just to make sure you're on the right path. Option B, metabolic bariatric surgery. I would also recommend that. It's among the most effective and durable options for patients with severe obesity. But these are higher requirements than previously listed. Like previously, it was about 27 to the 30 range of BMI. This medication is actually within the 35 to 40 with comorbidities. Surgery commonly produces large, sustained weight loss and can cause remission of type 2 diabetes and improvement in cardiovascular risk. But what a lot of this society doesn't understand, getting a surgery doesn't make you immune to obesity. You can still become obese. So that's why it's crucial, after you do the medications, you do the surgeries, you basically have to change your lifestyle to maintain the weight that you have lost. So yeah, that goes along with the regular follow-up and monitoring that's required. Surgery carries surgical and long-term nutritional risk, like micronutrient deficiencies, the need for lifelong supplementation. It requires committed long-term follow-up and is best for those who meet the surgical criteria and have tried conservative measures. Pre-op evaluation and multidisciplinary support matter a lot. And if people ask how to choose between them, basically for a client with moderate obesity who wants to avoid surgery, like I said, try the GLP-1 under medical supervision first, plus a structured lifestyle support. For someone with severe obesity or uncontrolled diabetes despite medical therapy, again, out of the range of your socioeconomic status, your nutrition, your diet, just factors that you cannot control, despite medical therapy, surgery may be recommended and it provides greater long-term weight loss on the average. Practical counseling and ethics. They always assess mental health, mental health being upon the biggest, and one of the known medications is Ozempic, and I've known many scenarios where mental health was like one of the driving factors in failure to the medication. And eating behaviors. A medication is not going to work on its own. Nutrition is almost 80 to 90% of everything. You want to have good eating behaviors before starting intensive treatments. You want to focus on health outcomes and functional goals rather than just moralizing weight. It's more than just underlying fat.